a doctor of physical therapy. I own a practice here in New York and in New Jersey. New York practice is new this month, actually. And I specialize in endometriosis and chronic pelvic pain. And I am so happy to have been invited here by the Endometriosis Foundation of America. I speak all over the world. I've spoken in China, Brazil, Colombia, and it is such an honor to come here and to speak in a place that meets my mission, which is to diagnose earlier with proper diagnosis and encourage a full quality of life for women. And to me, to be with this organization, it's like coming home. And I'm so happy that you all came today. So let's talk a little bit about pelvic health physical therapy. Did both mics, are they both on? Okay. I feel like maybe if I'm still, this one's clearer. Pelvic health physical therapy is a multidisciplinary approach to the body. So I always say we're another tool to add to your toolbox. So like Padma was saying this morning, you shouldn't just shove the pain away or use treatments to shove the pain away. Physical therapy is something that works with the team you're working with. So we work with your gynecologist, we work with your nutrition, and we put everything in a toolbox so that you can help yourself with what we're using. It's performed in a private one-on-one treatment setting, so no, I'm not doing pelvics in the middle of a big physical therapy gym. And this is advanced training. This took above and beyond my doctorate, 3 years of training. And like I said, we're a crucial team member to treating endometriosis. Today I'm going to talk a little bit about the physiology of pain. We had a snippet of that by the acupuncturist that just spoke. And the deal is that the brain and the pelvis, they can be friends and they can work together and be happy and they send happy signals and everything works great. Or they can be complete and total foes, meaning that they're working against each other for you to have the quality of life that you're looking for. So pain is a sign that something in our bodies is wrong. It's a response to noxious or bad stimuli that is damaging the tissue. And nociceptors, or free nerve endings, are receiving this stimuli, and they're getting damaged. And damage can occur in 3 ways. Mechanically, pressure, growth, tumor, something like that. Thermally, by burning or scalding. And chemically, with ischemia or toxic substances in your body, or even infection. So here's the deal. All 3 types of that damage happen in a patient with endometriosis. So first we have mechanical pain because there's endometriosis in there, and that has it puts pressure on all the tissues. The other thing is if someone receives cautery or it's lasered out again and again and again, you're getting a burning or a scalding. I don't know if we showed videos of what that looks like, but there's actually eschar, which is what we treat in burn patients, all over the inside of the patient in somebody who's been burned repeatedly through non-excision-based surgeries. And then also there's chemical, because there is minor infections that go on. Somebody was saying they had peritonitis. You can get ischemia, you can get cell death constantly, and so you have all 3 types of damage going on and assaulting these pain fibers over and over again. And the pain fibers, there's 2 different kinds. There are ones that are found in the somatic structures, so that's the skin, the bone, the connective tissue, and the joints. And then there are also pain fibers found in the visceral structures, liver, GI, uterus, and ovary. So here's the deal. Does endometriosis only hit one kind of pain fiber? No. At least somebody shook their head. I felt like something else. So if this is your pelvis, you have bone, you have connective tissue, you have skin, obviously, and you have visceral structures. So once this signal of pain is being sent from all these structures, so even though the disease may be in your uterus, maybe in your ovary, maybe in your fallopian tube, the pain signal is sent from every free structure that's down in your pelvis. And then the transmission of pain, it goes actually to a part of your spinal cord. That nocifiber goes into the dorsihorn of the spinal cord. It goes up the spinal cord into the brainstem, and then it forms connections within your brain. And so it's very hard. So your pain is in your pelvis, but all of a sudden the pain actually has created neural pathways in your brain. And here's the thing. Here's the real kicker. Nociception and recognition in the brain happens within the first 6 months of onslaught of pain. And the average woman goes 8 to 10 years before they were diagnosed. Show of hands, who was diagnosed within the first 6 months of feeling pain? Show of hands, how many of us took 8 to 10 years to be diagnosed? 23 years, 28 years, right? So all these neural pathways have really been able to set up camp. And it's very, very difficult. And this is why I love coming to an event that's geared towards nurses, especially high school nurses. You are the gatekeepers of care. You are the first people that meet the patient, that meet the young woman the day they have pain. What do? You call, I have pain, I call the doctor's office, I get the nurse first, right? My little girls, I spent a lot of time working in athletic training rooms and working in middle schools and high schools as an athletic trainer and as a physical therapist. They have cramps. Who do they go to first when they're there? They go to the school nurse. You're the gatekeepers of care. So instead of it taking 8 to 10 years to diagnose and the neural pathway is really taking a hold of this woman, you could cut down that time just by mentioning endometriosis and just by advocating for your women to have care, for your young women. The key to approaching ongoing pain in the patient, now post-excision, because now we hope that they've gotten their way to excision, is physical therapy. So recently I've done a lot of work with a doctor named Maurice Chung. And we were out at a social event, and he does a lot of work with endometriosis and IC, but he made a fantastic analogy. And he says endometriosis is a lot like this house, right? All your houses are in a row, right? And this is the endometriosis. Now, this could be your hips, this could be maybe your bladder, this could be your back pain. And here's the thing, we took care of the endometriosis in excision surgery, right? So suppose this house caught on fire. That's like having endometriosis. The house is on fire. Well, if this house is on fire, what do you think happens to this house? And what do you think happens to this house? They catch on fire too. And once we treat this, we treated the endometriosis as aggressively as we can with the excision surgery, with proper care, proper diagnosis, with a good team. All of these other houses still have the embers that flew onto them. And physical therapy, and we discussed a little bit acupuncture, are great ways to calm the rest of the fire and feel better and get back to the best quality of life you can have. So today we're going to talk a little bit about your pelvis. It is a compound structure that's goal really is to close the outlet at the bottom, mostly so you don't leak urine, you don't leak feces, and the goal is to close that structure. And it has a pelvic floor, and it has bones and muscles and fascia and ligaments and viscera. And there's all these muscle groups in here, and this is why I brought the pelvis with me. So that I can show you. Because although when we were in China, they did a live pelvic floor evaluation, I didn't really think it was so appropriate here. So this is the bottom of your pelvic floor, and these are filled with muscles. So if you're going through life 8, 9, 10 years, and you have horrible pain, and all you can do is just basically double over all of the time, these muscles that sit at the bottom of your pelvis, and you can see all the organs that are inside, they go into spasm. There's a great article by Fred Howard that talks about how 90% of women with endometriosis have spasms within the pelvic floor and the associated musculature. And, you know, the principal function of this pelvic floor is to provide support for all the organs. So if the anatomy is distorted from endometriosis, it's very hard for that pelvic floor to provide the support that it needs. So here we go, we have a nice, I just showed you all these muscles, but this is your pelvic floor. This is a sling-like muscle called the levator ani group. A lot of the patients get a lot of their rectal pain from this group in here. This is obturator internus. A lot of your hip pain comes from there. Mostly because those with advanced disease, the ovary affects obturator internus pretty directly. And you can see that everything that goes on in the bottom of this pelvis is muscular. So I had a patient this week, and the husband came to therapy, which I think was wonderful that he was showing support. And I went to do the exam, and for 10 minutes while I was doing the exam, he stood there and he said, "You mean there are muscles in there?" The whole bottom of the pelvis is muscle. And it's very important when once the disease has been excised, the muscles themselves need a little help for you to go back to life as normal. Sometimes inside the muscles we get myofascial trigger points. And so who gets that? Like their neck hurts here, and they push on it, and then they get a headache. Does anybody here get that? Yeah, a few hands. So like you get that in all of these, right? And so it usually is from what's called a shortening of the sarcomeres, which is the actual muscle fiber. And then the muscles try to elongate really quickly, and you get a little ball in the muscle. And once you get one trigger point, one begets another, and begets another. So you get a lot of them. And they can mimic gallbladder disease. They obviously can mimic endometriosis, bladder disease, and even cardiac symptoms. And they come from trauma, which we've had plenty of. Some people say they come from the surgery itself because it's so traumatic. Chronic muscle overload, nerve compression, structural asymmetries, postural stress, pelvic torsion, hypermobility, hypomobility, tight clothing, and basically the kitchen sink. You get a trigger point from everything. And in the pelvic floor trigger point, you get pain around the tailbone. So I'm going to point just in case there are. So some of your pain around the tailbone can come from a trigger point. You get pain in the coccyx, which is this little tiny bone. You can get pain in the rectum, pain in the genitalia itself. You can also, there's a specific trigger point that causes you to have frequent urination and have that sense of burning all the time. And it comes with back pain as well. And then in recent studies, patients felt an improvement of symptoms with the PT given to the pelvic floor directly on trigger points. The other thing that we work with in pelvic physical therapy is the fascia. And fascia is the endless web between all cells, muscles, nerves, ligaments, and organs. It is connective tissue filled with collagen fibers that are wavy or parallel, or sometimes confused. So sometimes they're wavy where they're supposed to be parallel, and parallel where they're supposed to be wavy. And usually that's what happens in the case of adhesions. The tissue just did not lay down in the pattern that it was supposed to lay down in. And fascia is a tricky thing because it's supposed to be flexible and it's supposed to be strong. And sometimes it's strong where it's supposed to be flexible, and flexible where it's supposed to be strong. And you can get dysfunction within the fascia itself. And this fascia is supposed to provide support for the whole body. And if it gets confused and it binds where it needs to glide, what happens is your body just doesn't know how to adapt. And that's one of the things that we work on in physical therapy through myofascial release, through craniosacral, and through many other techniques. Myofascial release is a soft tissue therapy used to treat dysfunction and restriction in this fascia and usually that restriction results in pain. This dysfunction can arise from psychogenic disease, overuse, trauma, infectious agents, surgery, postural issues, and inactivity. So basically like everything we live through every day with endometriosis. fascia, once injured or inflamed, will fail to provide its glide until it's encouraged. It has to be gently encouraged back into health. And there are certain forms of myofascial release that serve to down-regulate that fight or flight mechanism that we walk around living in constantly. They really help the body recoup from years of trauma. I happen to use cranial sacral for that particular technique. Visceral manipulation is another form of myofascial work. It is developed by a French osteopath, Jean-Pierre Barral. It evaluates the structural relationship of the viscera, the fascia, and all the ligamentous attachments. And tension patterns form through this fascia, and the body compensates by creating fixed points and chronic irritation within the organs itself. So the body is constantly trying to respond to the disease that's in it. And also, if you have adhesions, for those of us that have had surgery, if you have bowel adhesions, if this is one way, this is a technique that you can use. It's a gentle, light touch technique that you can use to help balance the body around the adhesion. You cannot break the adhesion, but you can help get the body adapt to the adhesion. It provides proprioceptive input from this organ that may have the adhesion to the brain to send a different message. So the key to breaking that pain pathway that we were talking about is to send a new message, to drive the train down a new track that says, I am healthy, instead of, I am in pain. And visceral manipulation is one technique to use that. Another issue with the pelvis, and so not all physical therapy, especially women's health, physical therapy is done internally. My teenagers that I work on, I never do internal work. I mean, the last thing, it's bad enough when you're a teenager that you have this disease and your association of your pelvis is like disease and doctors and ultrasounds and colonoscopies and all this. We want to create a healthy message between the brain and the pelvis, and when I say a happy pelvis, and I don't do any internal work on young teenagers. What I do is I work the muscles in close proximity. So I work piriformis, I work obturator internis, I work all of the gluteals and all of the abdominals. Now, abdominals provide so much support when that floor is in spasm. They provide so much support against the pelvic floor that they can kind of cover a spasm here or there. The abdominals also, especially post-surgically, can go into spasm, and you can get like a horrible trigger point that mimics endometriosis. And actually next month I'm going to give a whole presentation down in Washington, D.C. about how the abdominals can create a false pelvic pain. And the other thing is you have to have your respiratory diaphragm working to expand, to get the lungs moving, and also to calm the system. The way that you breathe really helps calm the system rather than amp it up. The calmer the system is, the more the system is going to be able to regroup. So there are many things that I do. I do stretching, I do manual therapy, I do strengthening. But one of the things that I do in my practice is I use yoga and Pilates in a one-on-one custom designed program to help treat the associated musculature of the pelvis. So today, the Endometriosis Foundation of America asked me to do a little demo. And I need some volunteers. Who are preferably wearing pants because we're going to crawl around. Please don't come on up. If you want to volunteer, just come up. I need 2. I know. I watched all you walk in and when they have pants on because I got a little nervous. All right. So the first pose that I would use to treat pelvic pain would elongate the muscles in the back and would also help strengthen the core. And what I would so this is my demo. This Kim, yay! So the first thing Kim's going to do is she's going to jump her feet apart, right? We're going to, can people see? Yeah. We're going to come on up to the stage. Oh yeah, don't fall off. Yeah, please don't fall off. All right, so now I'm nervous, you're going to fall. The first thing that we're going to do triangle pose. We're going to jump our feet apart. Right? You're going to put your arms nice and wide. You're going to turn one foot towards the wall,
All right, and we're gonna reach, and down. Good. And then I usually have patients hold it for 30, but they yelled at me that I was taking up too much time. And we're gonna come back up. Good. Jump our feet together. Right? And here we go. Jump our feet apart again. You're gonna turn one foot towards that wall. Good. And we're gonna reach, and come over. And so this is one way of opening up all the muscles I described before, and then you're gonna come up. Good, and jump your feet back together. And should we do maybe one more, because they were, you know what, I think maybe we'll do toe taps. So I'm gonna do one more in the interest of time. So come on down to the stage. I usually say, come on down to the mat, but I don't have a mat today, so you can sit down. And if you could put your head at that end. Okay, so let's go ahead and lay down. You're gonna bring, here we go. You're gonna inhale, exhale, lift your leg up to 90, right? Inhale, exhale, lift the other leg up. Good. Now, I'm gonna let go, so it's all up to you. You're gonna keep your sacrum on the mat. Okay. Inhale, reach the left leg away, holding the shape. Good. And exhale, come forward. Inhale, reach the hip away. Exhale, come forward. Good. Now inhale. Now we're going to make it harder. Exhale, reach the leg away. Inhale, back. Exhale, reach the leg away. Inhale, back. Now let's try to keep that shape. Exhale, reach the leg away. Inhale, back. Exhale, reach the leg away. Good. You ready? Inhale. Exhale, reach both legs away. Inhale. Exhale, reach both legs away. Inhale. Exhale, drop one leg and drop the other. Let's one of the things that this particular we have patients doing exercises within the first few weeks of surgery because you've gone and cut into the abdominals. And you really want to take a chance to rehab all of the muscles and get them stronger. And that's one of the ways that we do it. So as a physical therapist, my governing body is the APTA, or the American Physical Therapy Association. And the ATC came up with this new mission statement for Vision 3030, like Vision 2030. And what it says is, physical therapists help you move forward. And you know, being a physical therapist, I have to honor my professional organization. And endometriosis places an unimaginable burden on our bodies, on our minds, on our families, and in our hearts. And I first heard this APTA mission statement of move forward on probably the worst day I ever had with my battle with endometriosis. I was in the car on my way home from an egg harvest that failed to yield even a single egg from my last and only remaining ovary. Yet between all the tears and all the grief and all the anguish that was that day, I heard this on the radio, advertisement for physical therapy, and it said, move forward. And I thought these words are very true. This is exactly what I do, professionally and personally. We, as a community of 190 million women, we move forward. This is the crux of what physical therapy can provide patients with endometriosis. We do not cure the disease. We do not remove it from the body. I don't do anything hormonally. But we teach the body how to live life to its fullest. We move forward. Move again, breathe again, play again, laugh again, enjoy sex again, go to school again, whatever makes you happy. Find what makes you happy and move forward. This is what you need to do without being overwhelmed by your pain. And this is what physical therapy or women's health physical therapy can help you do. You can
move, go forward through the pain, through the darkness, through the trauma, and have a happy and healthy life. Thank you very much.